being talked about here, PMJ, and it covers the bottom 40 to 50% of India's population, which is around 10 to 11 crore families, which is around 55 odd crore people. And the scheme essentially says that if you have a medical emergency for secondary or tertiary care, then you can go to any empaneled Ayushman Bharat hospital. It could be a government facility or a private facility, and you get the treatment done in a cashless manner and up till rupees 5 lakhs per annum as a family. And essentially, we know that health emergencies are the biggest reasons why families get pushed below the poverty line in India. And therefore, it was a big step that the government took through PMJY or PMJ. So what I want to understand from you, Dr. Indubhushan, is what were some of the design principles or the principles that you kept in mind at the very start before actually putting down the scheme on paper? We talk a lot in B schools around design thinking, design principles. What are some of your principles there?
Okay, so for a scheme like this, and I think that framework is there for any scheme that you are asked to implement, you have to see at least 5 things. One, who is the beneficiary exactly, and how are you going to identify the person, and how are you going to tell the person that you are eligible for the scheme, and when you go and how do you access services. So one is demand side on terms of identifying the person, right? Second is what kind of services are to be provided. And it can vary from scheme to scheme, but for PMJ, is it tertiary care? Is it outpatient? And within tertiary care, are we going to be opening it up for everything, including elective surgeries or cosmetic surgeries? So a call has to be taken by what are the services that are going to be covered. Third is that how much are we going to pay for those services, and how you're going to be paying for services, in the sense that you can decide the payment, but the same service being given by, say, Max or a district hospital, are you going to be paying them same, although their cost structures are different? Are you going to be paying them based on fee for service or just lump sum based on the contract? So that has to be taken. So the fourth thing is that who will make the payment? Will it be the government directly making the payment, or are you going to be hiring insurance companies to be making the payment? If insurance companies, then how are you going to be selecting insurance companies? And all that process has to be done. And finally, the system, who is going to be implementing it, who is going to be monitoring it, who is going to be putting together grievance redressal system, who is going to be looking at the fraud and abuse system. So all this, so these 5 elements are there in any scheme, irrespective of what kind of sector you are in.
And if I will just paraphrase what you're saying, Dr. Bhushan, essentially you're saying identify the target segment,
yes,
which is the people who are going to benefit. Then you finalize your product, which is what all packages you're offering in this scheme. You finalize your pricing, and it's going to be differential pricing, or it's going to be the uniform pricing for everyone. And then you're talking about the mode, which was the option, I think, in the beginning given to the state to say that they can either directly pay the amount of the treatment, or they can onboard an insurance company to whom you pay a premium, and the insurance company will then do that. I think most states, opted for the first one, if I'm not mistaken.
There was a lot of politics on that. But one thing I forgot in these 5 things is that who was going to be providing services? Is it the government service, government hospitals only? Of course, government hospitals are already providing services. But private hospitals, then what kind of private hospitals? Whether we are going to be including traditional healthcare dealers, and how are we going to be impaneling private hospitals? What will be the criteria, and what are the kind of contract we are going to be having with the hospitals? So that is the 6th element also, which was done. So based on this, I had 4 verticals on the first week in time. I said, okay, I need 4 verticals. One is the demand vertical, and I need a very strong communication team. It's a new scheme, so you need to have a logo for our scheme. We need to have logo for our organization. We need to have a communication campaign to towards beneficiary, but also communication campaign towards hospitals so that we can attract them and try to. So that was put in place. We hired an agency. Second was a very strong vertical on IT because, if you have to reach 500 million people, you have to implement the project, you have to monitor it, you have to ensure fraud and abuse is not done. It can't happen without a very strong IT platform. So we created IT platform end to end so that it can provide services paperless and cashless manner. So that was the second strong IT vertical IT. Third is technical people who will be looking at what kind of services are to be provided, at what rate, fixing the price, and what kind of hospitals are to be impaneled, what are the criteria, and developing all that. Fourth were systems people in terms of what kind of structure we are going to be having at national levels, state level, district level, what kind of people are going to be there, what kind of training is to be provided to them, and how that is going to be done. So